Welcome to Stem Cell Genius, powered by R3 Stem Cell. I'm your host, Samantha Breckner, president at R3, and each episode, I sit down with our founder and CEO, Dr. David Greene, to answer your most pressing questions about regenerative medicine. From stem cells, exosomes, and PRP to the latest breakthroughs in treatment and science, we're cutting through the noise and giving you real answers from one of the world's leading experts. This is Stem Cell Genius, your front row seat to the future of regenerative medicine. And we're back with Stem Cell Genius. Today we are talking about the top 11 common misconceptions about stem cells. We're going to be busting some myths today with our genius.
Yes, I hope I know the answers.
You should.
Considering the fact that I'm the one that made the list.
You are the one that made the list, so let's hope you know the answers.
I got this.
You got this. All right, well, let's dive in. We'll start with number 1. More cells equals better outcomes. Is that true?
So for a lot of conditions, yes. When you look at the clinical trials and peer-reviewed research studies that have been published to date, for quite a few conditions, you can see a significant increase in outcomes, better outcomes, when more cells are used. It doesn't have like a complete, proportionate line.
Right.
It does start to sort of drop off. You get decreased utility at a certain point. But yes, like instead of giving 500,000 stem cells per kilogram, you see better outcomes when you move it up to like 2 million stem cells per kilogram.
Sure.
For people who are, say, stage 5 kidney failure or, real severe. Now, when you talk about a confined space, like a normal sized joint, then that's not what happens. So people will say to our providers, well, you want to give 25 million stem cells for the joint. What about 100? Would I feel that much better? The answer is no. There's been numerous clinical trials looking at that, and the results you get from 25 million is no different than the result you get for 100 million.
Well, and it has a lot to do with the amount of volume that's able to be injected safely too, right? I mean,
Yeah.
a normal-sized joint.
Well, a normal-sized joint, let's say like the knee, right? You can get maybe 7 cc's in there. It's not going to feel good, right? But for a few days because of all the pressure. But you could get it in there, so to speak. There's room. But is it cost effective, and is it, that much better outcome? The answer is no. Now, when they went up from 25 to about 50, it did maybe last a little bit longer, but it wasn't really, to my recollection, it wasn't statistically significant. So for these systemic types of issues, yes, more is better. For focal types of
Depending on the
injections,
severity.
that's right. Exactly. Yeah. Like sometimes for a diabetes that doesn't have too poor control, 1 million stem cells per kilogram would be fine. For someone who's way off the bell curve with their, A1C and all that, yeah, more is better.
More is better.
Yeah.
Well, I think that makes sense.
Yeah, it's not exactly a binary answer, but
Right.
it is.
Well, that's why we offer free consultations, and we have our consultants that can learn and cater recommendations to our patients.
r3stemcell.com.
We're the best. We're not done yet, though. All right, number 2.
We made it through number 1.
I know. I'd give you like an A minus.
A minus?
A minus.
Well, it still fits in the bucket of an A.
It does. And I'm only giving you an A minus just because I feel like it. Minus sounds fun. All right. Number dose. All MSC sources are equivalent.
Yeah, so a lot of consumers don't really understand the differences, or if there are any differences, between the stem cells that come from yourself, for instance, versus ones that come from a donor.
Sure.
So what we found is that the average age of our patients is like in the 50s. Probably like my age. But when you look at, people who are in their 60s, 70s, anything over the age of 50, the quality of the stem cells that come from you are not great. compared to what else is available.
And even in our own bodies, we can get MSCs.
Correct, yeah. So you can get plenty of MSCs from your fat tissue, or, and you don't get so many from your bone marrow as you age, but you can get some. Yeah.
Okay.
So when you look at the quality of the cells from yourself, there's not as many of them typically than you could get from a donor. So it's a quantity problem. The bigger issue is the quality issue. You know, as we age, we get this chronic inflammation from the foods we eat, the medicines we take. Inflammaging. That's exactly right. Oh,
I learned that from you?
Yeah.
Oh, I do listen to the podcast.
Yes. We have one follower, at least.
Woo!
We have two, because I follow it too. But,
that's fair.
So anyway, that inflammaging, you know, really puts a sort of a blanket with oxidative stress over your own MSCs, and it hampers their ability to function. So you have less of them, and they're lazy through, you know, the inflammaging, and that's a detriment. Because when you look at the donor stem cells, such as from umbilical cord tissue, could be from amniotic fluid, although we don't really use those much at all anymore, or other, you know, types of birth tissues. The stem cells are very, very young. They're very potent. They're very pure, and they don't have the baggage of the chronic inflammation.
Right. So
they just tend to work much better from what we've seen. The literature is bearing that out as well. So people need to understand they're not all the same, depending on where they come from. Absolutely.
A+ on that one.
Yeah, thank you.
Thank you. You're welcome.
Where do I go from here?
All right, number 3. Injected MSCs and graft and become new tissue. Is that true?
It depends. So we'll start with one side of the equation, then I'll talk about the other. So if a patient is having a treatment for, so let's say, cancer, with a bone marrow transplant, the first step is to basically knock out their immune system, right? I mean, it's called a myeloablation. You basically reset it almost to zero, and then you're replenishing it with either bone marrow from a matched donor. I mean, it could be from yourself, but the hope is that you're going to find a donor. It could be a relative or somebody unrelated who just happens to have, and that will replenish your immune system. In that case, you will have 2 sets of DNA at the end of that, because it does engraft, and it's what's called becoming a chimera. You could also use, there's umbilical cord blood now too that is a good second choice. You don't have to have a 6-point match. It could be maybe a 3 or 4 point and do well. That's one side of the equation. We're not doing those treatments, right? We're not knocking out the immune system. Most people who come to us either have a competent immune system or one that's slightly suppressed from either steroids or whatever. And for those patients, we don't have any evidence that there's any engraftment of the tissue into creating new DNA in your system.
Okay. That's nice. You know, I honestly, out of everything we've spoken about, that's probably the number one question that I get from patients, or that I even see on our social media, you know, like, is it going to change my DNA when I get it? If the donor has this and this and that, am I going to develop this and this and that?
Exactly.
The answer is no.
The answer is we don't. I mean, there's plenty of studies that have been done on this. If you give ridiculously high doses, then maybe in a small animal you might see a little bit, but not in. We haven't seen any of that in humans.
Yeah, at least we haven't seen that.
Right.
Okay. All right, we'll move on to the next one. Culture expansion doesn't change MSC properties. Is that true?
Once again, it depends. We have a lot of competitors who will say that it does change the MSC properties, therefore you shouldn't go out of like the United States to get treatment. But that's not the full story. The story, and I'll say it very concisely, is if you culture or expand mesenchymal stem cells properly in a GMP compliant lab using reagents that are GMP compliant, then for a certain period of time, those stem cells really are first rate, and they act fantastic when it comes to the regenerative properties that we want and that we see. However, if you either use non-standard culture practices or you culture too many times. So we use the term passages scientifically, but we might as well use the term generations. If you go past the 6th passage or generation, then it does start to change the properties of the mesenchymal stem cells. They don't have that octopus kind of spindly appearance anymore that you want. They don't. They start to look kind of amorphous blob. They start to produce harmful growth factors instead of beneficial growth factors. They start to not have the capacity to promote the proliferation that we want to see with cells. And the term is senescence. It looks like a stem cell. It might have one or two of the surface markers of a stem cell. It's just non-functional. That's what senescent means.
Okay. And at R3, remind me, what's the highest generation that we go to?
So in the United States, they're all passage 0 because we don't culture at all. That's not allowed. Internationally, yes, we are allowed to expand. So the most we'll go to is passage 5, below what the International Society of Stem Cell Research. By and large, we just go to passage 3. Passage 3 is completely copacetic, and I would say 90% of the time we just go to passage 3.
Yeah. Hear that? Passage 3.
So just to, before we go on to the next one, that's one of the problems that most of our competitors have.
Yes.
Right? Is you'll get a quotation that says, oh, we're going to give you 100 million stem cells for like 2,500 US dollars in Mexico, for instance. First of all, it costs more than that to produce properly stem cells with the safety.
Well, and quality testing.
And quality testing. To do it right and to get the best outcomes, which is what we strive for since day one, is it's not cheap, right? And we do
but
it.
We're not the most expensive.
Exactly. We're not the. We're very affordable for what you're getting.
Right.
A lot of the competitors, if you look at their stem cells under the microscope, they're a blob, they're non-functional, and they're dead.
Yeah.
It's like a graveyard. Yeah, exactly. It's a disaster. We get so many of those calls every week. I went to this entity, and I don't know if it was a scam, but it didn't work, and
I paid this much. Can I pay that much again with you guys? And we're like,
we'll work with you.
We'll work with you. Right.
Yeah.
We'll work with you.
Yeah.
The next one is autologous is always safer and better than allogeneic. And then before you start, can you give us a reminder, what is autologous and what is allogeneic?
Sure. So auto means self, and allo means other. So autologous means that the tissue comes from, you, the patient, whereas allogeneic is from a donor. So it's funny because years ago when I was in practice doing like total joint replacements, we always used to have people donate their own pints of blood in case we needed them after surgery. And then studies came out showing that a lot of people have diseases and they don't tell you or they don't know, and then but when you look at the testing for those pints of blood at the blood bank, it's really the same quality testing that we do on the donor tissue, and they found that there was no difference in the safety on a large scale. And the same is true for the donor tissue. We test for whatever the FDA has on their regulatory handbook for West Nile virus, hepatitis, HIV, a broad slate. And we test for bacteria, virus, fungus, and endotoxin as well. And we've done 28,000 pretty much procedures around the world over the last decade, and it's been very safe. This is wood, knock on wood, to date. And it's very comforting to know that testing doesn't change wherever we are in the world.
Right.
The other factor to just keep in mind is that when they're taking the tissue from you, the patient, there is a harvest, right? So it's a big fat needle that goes into your pelvis, the iliac crest, to pull out the bone marrow. And some studies show that can be painful. There's a lot of nerve endings there. And for adipose, it's a tumescent liposuction, like a mini liposuction. But nevertheless, it is a procedure. Some patients, that's not common, but you could get an infection, you could have some pain. We've seen some patients get what's called a seroma, like a non-infectious, wound drainage. So there can be some issues with the actual harvest. You don't have to worry about that with the donor tissue.
Right. So what I've heard so far with the donor, there's no pain because not needing to do any, adipose or bone marrow procedures. It's not going to change your DNA, and they don't go through inflammaging.
Right. There's one other thing that I think is really important to point out. If an individual comes in and they need, let's just use that round number, 100 million stem cells, you can't get that from a 60-year-old's bone marrow or their adipose without expanding, right? So we can get that from our off the shelf, so to speak, out of the freezer, whatever, the donor tissue, but you can't get that from, someone coming in the office and taking the tissue and spinning it, and it just doesn't.
And if you're 60, so are your stem cells.
Right, the numbers just don't add up.
Right, absolutely. Anything else you'd like to add before I move on?
No, I think we busted that myth.
We busted it.
Busted! We should do that every time. We should do that every time.
Okay, all right.
Yeah.
All right.
Yeah.
I like that. All right, next. MSC therapy is a one-time permanent cure. Why is that false?
So first of all, it was never my intention to try and express my vocal range. If we do the busted, I can't guarantee that I'll be at a certain key.
Okay.
I don't even know what the keys are.
I'll go low, you go high.
Busted.
Perfect. I think we're better on the higher notes, especially when we usually sing happy birthday to the staff members.
Yes.
Yeah, we have a whole thing. Trust me, you don't want to see it.
We've had some PTSD after that.
We have. We need some stuff. So.
They wake up at night, make it stop.
Make it stop. All I hear over and over again is, to you. Oh, goodness. Nobody's going to want to listen to our podcast anymore.
I know, but just to, let people out there know, I can do that on demand. Like, if they want me to call a loved one and belt it out.
Busted!
All right, so let me read this again. MSC therapy is a one-time permanent cure.
Correct. Why is that incorrect?
Yes. So that is what patients want. Obviously, everybody wants that. They're like, oh, my knee hurts. I want to come in and get a one-time, injection with mesenchymal stem cells, and that's it. Unfortunately, that is not the case. Especially when we go into, this has happened many times because we're in 8 countries. Every time we go into a new country, there's a lot of education that we have to do. And that is, unfortunately, one of the things that, people ask.
Right.
Like, I don't need this again, right?
Busted.
Yeah, busted. So, usually patients will need repeat procedures. That's the fact of where we are with modern stem cell therapy, and it's going to be variable. Like we have pro athletes that are our ambassadors, and we do their procedures like every 6 to 9 months because they're pounding away on the football field or whatnot. But an older individual who's just trying to take walks with their loved ones, play with their grandkids, they might be able to get away with a few years, with arthritis. But when it comes to other issues like diabetes, or especially if it's not well controlled, or kidney failure, or things that are a little more, systemic and serious. Some people need a procedure every 6 months for a while, and then we can start to maybe space it out.
Right.
So, that's
it probably just depends. Everybody's different. Like, I wish we could predict how they're going to react to the therapy, but you just can't. Everybody's different.
Yeah, if you look at one of the latest studies that was done on mesenchymal stem cell therapy for rheumatoid arthritis, the result was fantastic. Most patients went into remission for an average of 2.5 to 3 years. But if you look at the the curve of where some went into remission and others didn't go into remission, it was pretty decently broad. Some needed a repeat after a year and a half.
Sure.
But the average was 3 years, so it varies.
It does vary. Okay.
Oh, busted!
Everybody better get used to that.
I know.
All right. Next on the list. Ready?
Yes.
Higher passage / older, right? MSCs just need more cells to compensate. Is that true?
Yeah, so that is a true myth. It's
True myth.
If MSC is basically senescent, non-functional, the adage of, we'll just give you more, and
It's more nothing.
yeah, it's more lazy / on the couch eating potato chips, watching, I don't know, Oprah.
Pretty descriptive there. Thank you for painting that picture.
Could be Judge Judy
Fair.
instead of
Yeah,
Oprah.
don't hate on Oprah.
Yeah, no kidding. But yeah, you're just going to have more and more laziness going on. It's not going to be any more functional because you've added more to the equation. So unfortunately, it's not like, what's that old adage with Doritos? Eat all you want, we'll just make more.
We'll just make more. Yeah.
It's not like use all you want, they'll be more functional.
Right.
Right.
It's
Doesn't
not gonna
play
work
out that way.
Okay. And pretty sure we busted why.
Yeah. Busted!
All right. Number 8. You ready?
Yep.
All stem cells get trapped in the lung and die.
Yeah, so that's a pretty big one that we hear. And it's not a full myth. It's actually a partial myth. The stem cells do get trapped in the lungs.
So wait, let's clarify here. Is this specifically for lung conditions, like with a nebulizer, or are we saying in general?
Yeah, let's clarify. So if you do injections, you're putting it into a confined space.
Sure.
So they're not going to be like, I don't like the knee anymore, I'm going to go to the lungs. That's not really what happens. I'm talking about an IV therapy.
Or a
nebulizer.
Okay.
Right. So, if you do them intrathecal or other applications, then no, they're not.
Unless
going
there's
to the
truly enough inflammation.
Some of them might go
Not impossible.
systemic, I guess. But yeah, so when you give them, let's just talk about IV for a moment. You give a stem cell IV, it makes its way to the heart, and then boom, goes right to the lungs. The size of a stem cell is larger than a capillary in the lungs. So it does get stuck in the lung parenchyma, the lung tissue, but most of them do not stay there. They're able to, within about 12 to 24 hours, they will deform and get released.
Okay.
They can sort of work their way through. I was trying to, like a snake, getting through a tiny little, they can sort of deform themselves and make it work. Now, some of them will die, and that's just, part and parcel of the nature of stem cells. Now, exosomes are 100 times smaller than stem cells. They don't care. They just pass their way through. If there's inflammation, some stick around, because that's how stem cells and exosomes, find their exit ramp, as they look for inflammation.
So in result, they don't get trapped and die.
Some do get trapped and die. Most of them do not.
Okay.
They end up getting released, and then they circulate through the body. And they've done these studies in animals. Because you can't really, extinguish a human and then look in their various organs. So they've done them in animals who have similar sized capillaries like we do in the lungs, and they've seen that there's plenty of them that end up in the spleen, the kidney, other organs.
Okay.
Yeah. Busted! I like that going high.
I liked that for you. Probably not me. For you. All right. We got 3 more.
All right.
Feeling ready?
Yep.
All right. It doesn't matter how you give the biologics. Is that
So
true?
this is a good one, and it's a total myth. we had, God, we've been at this, every time I think about, the 14 years since I started R3 Stem Cell, I think about how much more information we've gained over the years. And it's really helped because outcomes continue to get better and better.
Right.
But when you think about how the applications are done now, so you have the potential around the world to do either just an injection into a joint, truly confined space, right? If the capsule is intact, maybe intramuscular. We know a lot more about that now. And IV, nebulizer, intranasal, intrathecal. And, some people do it like mucosal, submucosal, or subdermal, like for aesthetics types of applications. So there's a lot of different ways. And for anyone to think that it doesn't matter how you give those stem cells, they're going to get to where they need to go. It's just not realistic. So IV, yes, they go around the circulation. They kind of hit the exit ramp where the inflammation is, so they can go to numerous places. When you give them into a joint, they're going to stick around there for weeks and slowly leach into the joint and do their thing. When you give them intranasal, some of them go into the central nervous system. Some of them you swallow, and they basically just die from that stomach acid. Mm-hmm. And some of them will get systemic, So yeah, they're not all the same at all as far as how they work.
So question, pluripotent, doesn't that mean that they, continue to expand?
So we've talked about this numerous episodes. Pluripotent stem cells, in theory, are the holy grail because they can form any type of cell in the body, right? That's what we really want. But at the same time, they have not been shown to be safe, right? So they have the capability to form tumors. They can get rejected. But what Dr. Dazawa found, and in the very few clinical studies that have been done with Muse cells, is they don't form tumors.
Why?
And they don't get rejected
Why
either.
are the Muse cells different?
Because it's a spectrum. So on this end, you have unipotent, a stem cell that can only form one type of specialty cell. That's not very helpful, unless it's the one kind of cell you want. On this end, you have totipotent, which doesn't in reality exist. So then you have pluripotent. So what she found is that whereas mesenchymal stem cells are typically here, multipotent, they're more like here.
Okay.
So they're not all the way to the other end of the spectrum. Sure. So they're sort of like, not here, they're here, but they're not here. So that's where they sort of lie. And the fact that they endure stress is, in theory, good, like low oxygen environments, things like that. But we don't know. I mean, there's like this much research on mesenchymal stem cells and like this much on Muse cells.
Right.
So a lot of it's theoretical at this point.
Okay. But we do offer them now.
We do offer them, yeah. Okay, I didn't really fully answer the rest of the question. All right, so we do know that all mesenchymal stem cells are not the same.
Right.
And it goes back to the other myth we were talking about where, some mesenchymal stem cells are more towards that right side of the spectrum than others. Some of them have oxidative stress, DNA damage, and issues that just make them not so functional.
Right.
Right? Which goes back to...
Well, it depends where they're derived from.
That's right, yeah. So, if you're going to get mesenchymal stem cells at clinic A, B, C, D, you're probably going to get a different result depending on where they get their cells from and the quality of those cells.
Right.
The beauty with us is that it pretty much doesn't matter where you go. We're
the same at every clinic.
Yeah, we're USA-based standards as far as quality control and safety and everything,
even internationally.
In all 8 countries. Yeah.
Absolutely. Thank you.
Busted!
You're a little better than I am, but I think we harmonize well.
I'm going in the studio next week.
All right, last but not least, number 11. Safe embryonic stem cell treatments are available. Why is that false?
Yeah, so it is totally false. We need to bust the myth. Back in '97, so 28 years ago, the first embryonic stem cells were discovered in mice. And then about 5 years later, they were discovered in humans, specifically aborted fetuses or leftover, embryo after an IVF. So embryonic stem cells, we're now 20-some years into their existence, and none of them have been shown to be safe to use in a clinical trial. In fact, the clinical trials that have been done have had to use immunosuppression before giving them, which kind of defeats the whole purpose. So there are clinics around the world who advertise embryonic stem cell therapy, and obviously you want to avoid those. You want to run away from those advertisements because it's just not reality. There is one caveat. In our bloodstream, there's been substances called V cells, VSEL, very small embryonic-like stem cells. But what's been noticed is that they're non-functional. They don't actually do anything unless something activates them. And we don't really understand that very well. There was one study in the lab which used a laser frequency that showed that it could activate those cells. So I have seen clinics in Europe and others that take some blood from you, and then they spin it like PRP, and then they hit it with this laser frequency, and they tell people that you're getting an embryonic pluripotent stem cell therapy. And it's just not been borne out to clinically be proven at all.
Right. Well, and there's just so many other studies out there about why embryonic stem cells aren't safe in general.
Yes. Yeah. I mean, even induced pluripotent stem cells, which is where you take a skin cell, a specialty cell,
right,
and de-differentiate it back to being a pluripotent stem cell, even those have a plethora of problems. So, it's exciting to read about the research that's going on, but none of it has passed any regulatory authority. Notwithstanding the U.S. FDA, look at the less rigorous, nothing against them, but like South Korea and whatnot, they have plenty of, none of them have passed through there either.
Yeah.
Or India or, other places.
Right.
So.
What do we think?
Yeah, I think that's busted.
All right. Well, anything else you'd like to add about our 11 myths that we busted, that you busted?
Well, I think we'll do this as a part one. I think, we get tons of questions from around the world.
Yeah.
There's a lot of misinformation out there from either competitors or people who just haven't done their proper, education for themselves or read a bad source or something. So this was like the initial top 11.
Yeah.
But there's plenty more.
Most popular.
Yeah. So we'll pick it up on another episode with plenty more.
Bust some more myths.
Yes. We can range. Maybe I'll get some singing lessons before the next.
Yeah, you might want to. Just kidding. Sort of. All right. Well, visit us online at r3stemcell.com or give us a call at +1 844-GET-STEM to see if you or a loved one is a candidate. We'll see you next time on Stem Cell Genius.
Stem cell therapy is considered experimental and is regulated by the U.S. Food and Drug Administration, but is not FDA approved. R3 Stem Cell does not offer stem cell therapy as a cure for any medical condition. No statements made on this podcast have been evaluated or approved by the FDA. This podcast does not provide medical advice. All content is for informational purposes only and is not a substitute for professional medical consultations, diagnosis, or treatment. Reliance on any information provided by R3 Stem Cell, its employees, others appearing on this podcast at the invitation of R3 Stem Cell, or other visitors on this podcast is solely at your own risk. R3 Stem Cell does not recommend or endorse any specific tests, products, procedures, opinions, or other information that may be mentioned on this podcast. R3 Stem Cell is not responsible for the outcome of your procedure. The FDA considers stem cell therapy experimental at this point.